So welcome everybody. We're very happy that you could join us again for another Butterfly webinar where we try to bring some of the country's best experts to you and provide information around the use of point of care ultrasound and how it intersects with the way we practice medicine in different areas of disease. And I'm really happy to be able to do this month. It's a subject that's near and dear to my heart as a vascular surgeon, and certainly involved in cardiovascular care on the use of ultrasound and cardiovascular screening. So I'm joined with three incredible experts who are going to share their expertise and knowledge with us, and hopefully we'll get into a spirited conversation because if you want to talk about something that's somewhat controversial, the use of ultrasound for screening in cardiovascular disease is one of those. So I will tick it off to Dr. Thaman first to introduce herself, and then we'll go around the horn and begin what we hope will be a spirited conversation. Please feel free to use the Q&A function to ask questions of this group. The more you challenge them, the better this will be, so don't be bashful. Ritu.
Hi, everyone. My name is Ritu Thaman. I'm an associate professor in cardiology here at the University of Pittsburgh School of Medicine, and I have been involved using point of care ultrasound for over 10 years now, starting with a mission down in West Virginia where we screened 500 patients in 8 hours, and has led to me being the POCUS cardiology editor and also on several POCUS guidelines. So very happy to be here and look forward to the discussion.
Ben?
Hi, everybody. Ben Wessler here. I'm a non-invasive cardiologist at Tufts Medical Center in Boston. I'm associate professor here. Read cart-based echocardiography, and we have active research sponsored by the NIH looking at handheld ultrasound and artificial intelligence for improved detection of structural heart disease. So thanks for having me, John, and look forward to the discussion.
That's great. Joe?
My name is Joseph Entz. I'm the owner of Vasal Labs. We do cardiovascular screening for primary care for concierge programs that want to prevent heart attack and stroke. We specialize in carotid intima media thickness, analysis of the carotid for these programs, used as a tracking tool and a pregnancy test. If they've got plaque in their arteries, we tell them they're pregnant. I deliver this to clinics all around the country. I make beautiful reports, and I get a lot of good information from my doctors on the best preventative programs.
That's great. Well, I'll start with the first question. Why do we need screening? I mean, isn't it kind of obvious when someone has cardiovascular disease?
Well, let me start by saying it may be obvious to us, but to the great majority of Americans, even just having risk factors they're not aware of. For example, hypertension being the strongest risk factor, the majority, at least half, and that we're talking millions of people, do not even know that they have high blood pressure, let alone their numbers as proposed by the AHA of what their cholesterol is, what their fasting sugar or hemoglobin A1C is. Maybe they know their weight, but they may not know their BMI. So screening would work if people were more, say, cognizant of those numbers to start with. And if they were abnormal, then they would maybe pay attention to saying, I should do something to prevent cardiovascular disease. But as you know, right now, only the pooled cohort equation is what is really recommended, along with checking blood pressure for screening by the U.S. Prevention Task Force.
My favorite group of people. So people understand we screen for breast cancer. Why do we screen for breast cancer? So that we can detect it early and prevent somebody dying from it. We know we screen for colon cancer, and we know exactly to do that. But I don't think it's really common knowledge about screening for cardiovascular disease, and that's despite the fact that actually it's a leading cause of death around the world. And the vast majority of people, if you look at this statistics, and it's one I share with my patients, 50% of men and 63% of women, women always have to do things better. Actually, this is one of those categories they don't want to do better because of 50% of men, 63% of women who die suddenly from cardiovascular disease had no earthly idea and no previous symptoms that they had it. So clearly there's a role for screening in some regard. And maybe what we'll try to explore tonight is what's the role of ultrasound. Ben, what are the typical risk factors for somebody with cardiovascular disease? Who should we think about screening?
Well, I think sort of two comments that I'll add off the bat. One is that, as Ritu mentioned, we do screen for risk factors for cardiac disease, and those are things that are common and prevalent, right? Hypertension, lipids, blood tests, A1C, and those identify patients who are at higher risk, patients for whom additional testing may be appropriate, or more intensive behavior modification and or pattern changes be indicated. Really, when I think about sort of ultrasound in this space, it's to identify disease amongst patient populations that have higher prevalence of conditions that are treatable and higher domain of risk factors that can be modified. And that's why so many patients are left at risk without knowing, is because we don't do that in a comprehensive way today.
So we've set the bar at, okay, we're going to screen for, do you have the risk factors of vascular disease? Okay, we'll all agree upon that. You want to control your blood pressure, get your cholesterol down, stop smoking, and control your diabetes or don't get it in the first place. But that really, that's not enough, is it? We need to do more. Joe, how do you decide if you've got those things, who then needs more advanced screening and what are those tools? Is it ultrasound? Is it CT? Is it a stress test? What is the next level then if you identify someone with elevated risk? And maybe all three of you can answer, what's that threshold to say I'm going to go to the next thing? Is it just one of those risk factors? Is it multiple risk factors? Is it a family history? What kicks you over? Joe, you want to go first on what's that
Yeah.
next test?
The beautiful thing about what we do is there's no extra, I mean, there's no nefarious things going on. And I don't feel like it should be gate kept at all. I mean, in our perfect world, every doctor would have this stethoscope, the ultrasound around their neck, and they can show the patient what's going on. And depending on the room I'm in, I mean, 80% of people over age 40, 80% of them, I can show them something in their neck, a plaque, a little bump that doesn't look right. And it's real and they believe you. And it's the first time they've seen any evidence of cardiovascular disease because the cholesterol test doesn't motivate them so much anymore. But an opportunity to educate the patient, they'll come to you and be like, I'm at my dad's age when he had a heart attack. Well, that's enough reason to show them what's up in their arteries. I've got blood pressure, lipid issues. If there's no downside, then show it to them. And that's the first step to the education. And I like talking about the VIP Visa study, this research study where they showed the patients their images. They gave them comparisons to healthy and unhealthy. But after that exercise, and they induced a little bit of trauma, like they made the patient sit in that energy and see the plaque and kind of, I'm closer to the bad arteries than that exercise reduced the risk in that population by 50%. Just seeing their arteries reduced their risk by 50% in a year because it motivated them so much. So a screen is not only a tool to help catch it early, and because cardiovascular, it's got some of the longest lead times for boiling and broiling inside our body that, if you can show it to them 10, 15, 20 years before what's going on, they can make milder changes and get bigger results.
So I certainly know, and the data's there. We actually started learning it in Vietnam. The plaques start early, adolescents, teens, 20s and 30s, fatty streaks start to appear inside blood vessels. That is true. It is there. But I think Joe's statement right there, I'm going to show it and screen everybody. The task force people right now have jumped up and thrown a shoe at the screen. Why do they feel so differently than Joe does?
Well, I think there is a lot of older data that shows that if you screen with a pooled cohort equation, is what they recommend, that's enough. But truly, it is divergent from the statistics that we're getting out of the AHA, which shows that the amount of MIs, the amount of cardiovascular disease actually increasing, not decreasing at all. And certainly over the last decade, we've seen a sharp increase in younger patients. certainly those less than 50, especially women, rising rates. We shouldn't be seeing that here. And I think there is a role for screening. For example, when we went down to West Virginia, where you and I met back in 2018, these were just anyone can walk into the clinic. So no known prior disease, no risk factors, no nothing. Just come in, get a scan. We picked up 10% of cardiovascular disease, including cardiomyopathies and other valvular heart disease, and led to care that those people would otherwise not get that early on. And then subsequently, when COVID happened, again, we published on this that, using POCUS actually saved lives. That was the bottom line, because we could screen those patients that really needed urgent care more quickly. And that sort of has led to this uptake, not only in the sphere of, well, we're trying to prevent more spread of infection, but also picking up other disease that could be treated earlier on. Of course, everyone wants to see mortality benefit, but there is a morbidity benefit as well, because if you pick up disease and you can start treating it earlier, then presumably you have a better quality of life in follow-up. So I think that's would be very important.
So Joe talks about screening carotids. What did you actually screen in that West Virginia study? What was the protocol that you used that you were screening people with? And you were using ultrasound, correct?
Yes, we were using ultrasound. In fact, it was butterfly ultrasound. It was back in the day where it was, relatively new. And we were just doing an ultrasound of the heart, and we did very specific views. So normally we just did a, long axis, parasternal long axis view, and we went and did an apical. If there were other findings, then we might go and try to get another picture. And those, we were just screening for any kind of cardiomyopathy, any valvular disease, anything that we could see clearly, even if it was just a binary decision, yes, no. And that really, and that protocol has been published. We published it in JACE in 2021, and there was an actual difference in the hazard, and it was statistically significant when you compared it to just regular controls that just went on their routine way, didn't get the screening at all. And subsequently, that protocol has been also used in the ER that was published last year, where they showed that if you screened with an ultrasound in the emergency room, cardiac ultrasound, you could prevent in a low risk person, you'd save 1 day, but in a high risk person, you saved a length of stay, you shortened it by almost 3 weeks. So that's really significant. Obviously, they had more low risk than high risk, but still overall savings, cost savings, and savings to the patient.
So Ben, when they're doing screening for cardiovascular disease, looking for cardiomyopathy, but we also talk about valvular disease, which is a particular area interest of yours. Why is screening for valvular disease important? There are a lot of murmurs out there, but why is screening for valvular disease so important?
Yeah, it's a good question. So I'll answer in a few ways. I think number one, there have been a few studies of population-based screening with echocardiography, but the majority of them have been modest in size and limited to the days of cart-based imaging, where the screening was done with $100,000 to $200,000 machine. That is not today. And so these technologies, I think, force us to re-engage with those questions. And in the right hands, with the right interpretation, with the right conditions, again, which are not all assumed, there's an ability to make a dent on these conditions, John. And I think one of the things that's worth sharing with this group is that the world of structural heart disease and valve disease in particular is really evolving over the last 5 years, where there are now indications to intervene with surgical or percutaneous treatments for asymptomatic patients who have severe aortic stenosis, asymptomatic patients that have mitral regurgitation, also with aortic regurgitation. And so these conditions are causing adverse remodeling that may or may not be recoverable of the heart, despite a lack of symptoms for patients. And that's changing the interventional landscape for these conditions.
And just to tag on what you're saying, Ben, is that really is such an important point that you made, because people may not have symptoms. And for women in particular, by the time they present, they are so symptomatic that the level of disease that they're presenting with is so much more advanced. And therefore, they end up having worse outcomes when they actually get to surgery or percutaneous treatment. So especially in light of those statistics, I think it makes sense for us to look and find those patients earlier on. And it would be great to do a study to see that you could not only improve how quickly somebody was seen in clinic and got treated, but then also ultimately improve their lifespan because you caught them much earlier in their disease process.
So, and I can throw this at all three of you. So we're looking for cardiomyopathy and heart failure. There's the S3 with a stethoscope. Ben, you're looking for valvular disease. I can listen for that and I can hear a murmur. And Joe, you want to scan the carotid artery. I can listen to a bruit in a carotid artery. Why isn't a stethoscope enough? Every primary care doctor uses their stethoscope to evaluate patients. We know that. Every emergency room doctor does the same thing, and the cardiologist does the same thing. Why aren't those findings enough for screening?
Because nobody can hear a bruit properly. When I was a sales rep back in the day, we would duplicate the sound of the bruit or the heart murmur and try to give it to the docs in earphones so they could listen with their stethoscope and then order the right test. And that was a magnificent amount of training to get limited results. But yeah, listening doesn't tell you a percentage, doesn't tell you how much blocked, how screwed up it is.
I'll extend that comment that Joe made to the heart. I mean, there are fairly robust data looking at the performance of auscultation, both by primary care doctors and also by cardiologists. So this is not a comment only about general medicine doctors, but published statistics suggest that auscultation misses about half of significant murmurs, defined as moderate or severe left-sided disease. So, we've made the comment before that stethoscopes are the tool that identify physicians and are probably the least useful tool that we have, and yet they persist. So it's a problem. Yeah.
And the persistence is changing, I think, with those statistics that Ben has just mentioned. For example, now more than 20 schools, medical schools, are doing the white coat ceremony with an ultrasound machine gifted to the students rather than a stethoscope, because they really are replacing, because seeing is believing. You could see the S3 if you just put the ultrasound, and that way you not only are hearing it, but you're actually seeing it. You can actually see the valves open and close. So it makes a huge difference. It's just integrating that across, the whole span of physicians, starting with the medical students, all the way into, people who are just about to retire. There's a huge range. So we're talking a span of 50, 60 years of age, which, it varies substantially. But there's no doubt that an ultrasound is going to do much better at picking up a murmur.
So
That,
my favorite saying is, why listen and guess when you can look and know? And fundamentally, that actually is the situation that we're dealing with. The carotids, for instance, 50% of really significant carotid lesions, there's no bruit. And a significant percentage of bruits, it's the external carotid artery. So if I'm a vascular surgeon, care about the internal, it's there. But at the end of the day, I think the bottom line message for all of us is at least the regular stethoscope in the hands of all of us, even experts, is probably not a good enough screening tool. I'll take the next level. There are fancy stethoscopes that are coming out. You guys know Echo and Connor's out there building with artificial intelligence tools that are going to say, okay, Ben, I can hear a murmur and it's telling me it's a murmur. Is that going to be enough?
Yeah, listen, I think that these are spaces that need they need evidence. And we need studies. Some are coming out now about how these tools perform, and where they really shine, and then what the limitations are. And I think the field is young. And the other thing that I'd say is I think there's an anchor on physicians gaining access to these new tools, but I think there are whole care teams, right, that are really broader than that. And the imaging, I think we need to think about it more in the context of all of the providers who interface with these patients, not just the physicians or the older cohort of physicians who are going to be slower to adopt. And that's feedback I've gotten personally. So.
and that being said, I mean, you can imagine a future where you go to Walmart and you get your ultrasound sticker, put it on your chest, as a patient, and that image is then sent and read by AI somewhere, and somebody gets that diagnosis. So, they're already making those types of revolutionary changes. So as we adapt, I think this is going to be part and parcel of what we're doing, because the technology is really pushing us to do the right thing now.
We're kind of hoarders in medicine, aren't we? Like, you find something better and you don't get rid of the stethoscope. It's just people feel guilty, or it's the tool they're familiar with. And there's medicine improves over the dead bodies of people, old ideas sunsetting and new ideas beginning. But yeah, there's a lot in medicine, like the stress test, the coronary stress test. It's got a 17% positive predictive value. So even if you are sick, it'll catch less than 1 in 5 people with the proper diagnosis, but we still use it, and it's still the test that everybody thinks about.
It's interesting. I think about the new tools, and I don't know. I'm still learning myself. I buy the new Echo stethoscope and the new tools because I'm trying to figure out where it fits into my practice. I actually look at it, is it driving some things to the left of the, if you will, skill continuum. So I think these are tools that can help, our assistants, our APPs, and others kind of down. Even the medical assistants who are doing vital signs that listen, perhaps they're there and maybe they help me. I don't know. I'm exploring that, but I find myself thinking that, this is back in the day of Henry Ford, and instead of building a car, we're just building a faster horse, when a car is sitting right there, and that car is the ultrasound. Um, so where, as you guys have watched ultrasound evolve, what particular changes in ultrasound when it comes to screening for cardiovascular disease, what changes have you seen that may make this something that needs to move from, an ultrasound test was a test we ordered as opposed to a test we do? Where does that fit into this change to screening for the regular population in your hands, as well as the colleagues and what you've seen around the country?
It really boils down to how fast you can learn how to do the ultrasound yourself. And some people, obviously, if you're doing a fellowship, you're going to be trained on repetition and you're going to learn it. But a vast majority of people aren't getting that kind of in-depth education. In fact, there's a question in the Q&A, somebody saying, well, how do you learn? What's the process of learning? I think that's sort of the rate limiting step for most. The students are learning, the medical students are learning. And you can take, courses, but then that's hard if you're already working and then leaving your job and we obviously just have been discussing this at a conference, and there's no easy solution for that because that's the rate limiting step. You have to get good images. Now, the AI piece is really helped in that. Caption Health and others have put in AI into their gadgets, and so it can direct you in how you approach and where you put it on the chest and how you have to tilt and roll the actual probe to get the image. And then there's the red light, green light, yellow, tells you when you hit green, you've got a good enough image, automatically captures that. So that's been a revolutionary tool for us, because there's not enough of us to teach everyone. And you really have to get your hands on the probe. Now, obviously, people are going to know there's simulation tools that are happening. And I think that's going to be one way. And then the virtual reality teaching is the other way.
So I like the question about learning. So what do they need to learn? What tests should they learn how to use from a cardiovascular screening perspective? If they said, okay, I get it. I don't want to learn all of ultrasound, but I want to learn ultrasound for screening my patients. What exams should they learn how to do? And is it a full comprehensive exam? Is it a limited exam? What do they need to learn?
Well, it's being done in the emergency room and the primary care residencies. They all have to know how to rule out, say, catastrophic disease. So pericardial tamponade, where you have fluid around the heart, and it gets compresses the heart. Hopefully they can identify an aortic aneurysm that looks really enlarged, especially close to the aortic valve, and identify if the heart function is abnormal. So if there's a cardiomyopathy that can actually, those are at least 3 things that, they're learning across the board. Those can become very important at the bedside clinically. Of course, there's a whole spectrum, but those are really, they have to know that. The students are all tested on those.
Ben, what are you teaching people?
Yeah, the short answer is, I don't know, John. The longer answer is that it depends quite a bit. It depends on where the practice setup is, right? So are we talking about primary care? Are we talking?
Yeah, let's start there. Let's be focused, okay? The depends is a great answer because it does.
Yeah.
But okay, I'm going to give you 3 scenarios. Each one of you can pick one. Ben, you're going to train a family medicine resident says, I want to learn ultrasound to screen my patients. What should they learn?
Yeah. I think overall structure and function, which would be the long axis, and the parasternal position, and then the apical windows, will give you sort of a 10,000-foot view of pathology. But I also think it extends beyond just the heart, right? So there's a lot of focus for patients who are seen in clinic and have a symptom, so they're short of breath, to look at lungs in addition to heart. And so it's a slippery slope, but I think what I would say is that high-level structure and function questions, and then knowing what you either don't see or what you don't know, are critically important, because it's the misinterpretation which gives cardiologists pause in this field. And we need to sort of tread carefully, because it is not the same with limited protocols as diagnostic imaging in the echo lab, which takes an hour by an expert.
Joe, you're teaching the concierge doctor. What are you teaching them to scan?
Well, going back to screening, because you asked a really good question, and we started out the, screening with indication, without indication, and that's a whole universe. And before we were talking about pre-screening, and you kind of get stuck in all that. But my docs are using the butterfly as a tool to build their practice. They get a few minutes to spend with the patient to show them what's going on in their artery. It's educational, it's motivational. But the carotid is my favorite, but AAAs are a great one. That's a pipe that's real simple. It splits into 2. If they want to do femorals and get aggressive, they can do that too. But The screening you're going to do is the one that fits your specialty. And going back to my docs, they're delivering something that nobody else is delivering. It's a few minutes, you and me looking at your arteries, what's the state of them? And it's so alarming because the patient sees plaque, they see lumps and bumps, and eventually they look up at the doc and say, now what? And you have a motivated, enlisted patient that's willing to change their diet because they saw some junk in their trunk. And so screening, I mean, if there's no negative or downside outside of your time, then, I think let's bring back the healers to medicine where you can show your patient the damage they're doing to themselves and give them options on how to climb out of that hole.
I'm going to give you in a second after this to say what the downside is, or at least what's advocated. So, Rita, you are in the emergency room. You happen to be there. You've now been designated emergency room doctor. The patient is a 68-year-old diabetic who comes in with cellulitis of their arm. Are you doing any screening for cardiovascular disease on that patient, or are you going to give them antibiotics, treat them, and send them home?
Depends how busy the practice is and how many people are waiting, right? So
You
if
have
there's
the
no,
luxury to do whatever you want to do.
if I'm an ER physician, then I'm just not going to screen. I'm just going to treat the arm, and he's a diabetic, and hope that he has somebody who's going to talk to him about his cardiovascular risk profile. If I'm seeing him as a cardiologist, then, in follow-up, then it's a different story. Then I could say, hey, we need to do a few more things to really analyze what your risk is. Now, a majority of those types of patients, diabetics with an, arm infection, are going to get a coronary calcium score before they get anything like an ultrasound, because that's already in the guidelines. So we have those already incorporated to risk stratify. And so any other ultrasound that I would be doing would have to be if he had any symptoms. Because otherwise it's not really covered, right? So I can't just send him for ultrasound without a reason. Now, if he's just in the office, I can certainly screen because, you can clearly identify if there's LVH, which is a risk factor in it of itself for sudden cardiac death, for cardiomyopathy down the road, etc. Those are things we're not screening for right now, but potentially we could if it were accessible and, everyone's really knows what they're looking for. Now, there's a couple questions that are coming in the chat box, and one of them is, given the current prevalence of cardiovascular disease, where do you think our biggest blind spots in early detection, it says, still exist? Where do you think our biggest blind spots in early detection still exist? Probably the biggest bang for your buck is all the people lying around with hypertension in this country, right? The ones that they don't know their numbers. So if you could just take one look at their heart and see, do they already have left ventricular hypertrophy, or if you had a little bit more advanced, you could imaging, you could also see if they had diastolic dysfunction. Again, you would be able to prognosticate very well with just those two things. I think that's one blind spot that we could.
So let me throw out a controversial statement, spice things up a bit. So all of you have said that ultrasound is a much better way to evaluate a patient, and that all of you talked about how powerful ultrasound screening, if you will, would be to identify disease. You all have also said so many of these patients are asymptomatic. Okay. That's the context we live in. And we know there's 1 million heart failure admissions every year. The vast majority, maybe at least 50% of people learn they have heart failure when they're admitted to the hospital. And we certainly know about sudden cardiac death, about atherosclerotic disease, about stroke, about ruptured AAA. And I'm proposing it, let's tweak the word screening to, why is an ultrasound of the carotid artery, of the heart, of the aorta part of our physical examination. And then it's not about a screening test at all. It's actually about a much more accurate physical examination with data where you can accurately put a physical down on an H&P that accurately reflects what the patient really has. Does that change the context of what screening is? Ben, would you live in a world that does that? Does that make sense to you?
Yeah, John, I like the framing that you present. I'll offer a few comments. One is that my life is pretty simple as a non-invasive cardiologist in a specialized clinic. I deal with a set of problems related to the heart and cardiometabolic disease, and that's it. There are barriers to thinking about this upstream of where my clinic is, so in primary care. And primary care providers would need to shift how they examine patients and how they think about patients. And primary care clinics would have to shift how they examine patients and how they think about patients, oriented towards this sort of better look that you just described. And the pressures are immense for these providers. And it needs to be both with the technological developments that are really well on their way, but then also understanding how would that care be delivered at the bedside within the structures of how care is delivered, which is time sensitive, you know, often driven by patient concerns at the time, and then skill limited as well. And so there are barriers, but I think it's a very attractive approach to these tools and to pick up these conditions.
Somehow you could incorporate it into the exam as you suggest, John, which is being done by critical care medicine docs are doing it, right? They use their POCUS routinely, and they bill as part of their H&P because they're billing by hour. And so they're able to get reimbursed. The other people who are just doing it, if you're using the code 93308, which is the limited echo code, which is not really equivalent, but it is being used by ER and others. You're supposed to save the images. You're supposed to keep them in some archival fashion. You're supposed to have some form of a report. And that, like Ben is saying, that takes some kind of organization and infrastructure, which may or may not be present in the majority of practices or hospital situations around. It's not ubiquitous at this point.
So unfortunately, often is the case, and I think in many respects, Joe, you're trying to teach your doctors to actually function this way in the model in which I just described, which I think that's part of what you're doing. But we end up in medicine very much like the tail wags the dog. We'll do it if we get paid for it. We'll do it if we have time for it. But if we don't have time for it or we don't get paid for it, we don't do it. And as much as all of us believe, and we'd like to, that everybody's interested in the best for our patients, at the end of the day, there are other factors that drive what happens. And I think this kind of stuff, if you think about it now, we have the majority of medical schools in the country teaching ultrasound skills. So the doctors of the future, whether you're primary care, anesthesia, cardiology, doesn't matter, they're learning how to do ultrasound. The shift that has to happen is for us to think of it differently. And candidly, maybe the change is that once a year, there's a code for a ultrasound-based physical examination that reimburses enough to justify the time it takes to actually do that. But before that's actually going to get there, the things Ben brings up, which is really true, we got to know that people are not going to do something and find something that drives everybody crazy, the false positives. And that's what the U.S. Preventive Service Task Force is so against screening. The only cardiovascular screening test they really approve of, and they're getting closer, obviously, with coronary calcium score, but is screening the aorta for vascular disease, at least, in males 65 to 75 who have ever smoked. And what is the logic behind their recommendations? And that is there an adequate powered study that shows that it impacts mortality? They're not doing a study, Joe, based on does it change behavior. They're not doing a study that shows it improves compliance in taking medications and adjusting lifestyle and doing it. Nobody's done that stuff. And the other argument that they make, which is a really important one, and that is, well, it's going to scare people to know that they have a 3.9 centimeter AAA because it may never be a problem. So why did you find it? It's another big part of what the things they say. It's unnecessary psychological harms. And I think before we overcome that, I think it's going to be a challenge. And I think some of the points you guys are making, Ben, and I think maybe dive a little bit deeper into how valvular is different. Is it really going to make a difference to find valvular disease early enough because of the statistics you quote that should say finding it early matters enough that we have to move, and you guys are part of these professional societies where the recommendations and guidelines have to change. And I don't think they're there yet.
No, I mean, I'll respond, John. I think you're right on. I think that when we think about these issues, as I said, that a lot of these valve conditions and as Ritu said, get picked up quite late. There's an emerging body of evidence that outcomes are worse because of that. And so earlier detection of treatable conditions, and there's a laundry list of them, has the potential, John, to make people live longer and feel better. But I do think there needs to be an evidence base, and that's part of what we're working on, is there need to be studies appropriately powered to demonstrate that these tools actually change how people feel or function. There are plenty of folks working on that, and the guidelines will follow and the professional societies will follow, but they can't move until that evidence exists.
And I would just add to what Ben's saying about the fact that there's observational data that suggests that the cutoffs that we currently use for valvular disease cutoffs are different for men and women, but it's observational in women. So we can't really put that into a guideline. We can say that there's a difference, that women's hearts react differently to aortic stenosis. We're not going to dilate when we have aortic insufficiency in the same way. We're never going to get to those numbers that are in the guidelines, right? Currently, they're too big. And that's why women present later and more symptomatic, because they've just, been past that threshold for a longer time. And I think that that's an area where it could really make a substantial impact, because we're going to be able to get numbers, big numbers, like the database they have in Australia, which is like 2 million echoes. And you could really then delve in and find some information. Currently, we have some, but our data is much more divided up, and we have less huge echo/POCUS data that we can analyze. But the ones for POCUS, I'll just say, the image quality is essential if you're going to use AI or you're going to teach from that. And we don't have that in enough quantities yet. It's getting better, but we're still evolving in that space.
So how much of a difference does it make now that handhelds are around? Is that going to change the game versus the cart-based systems? Do you see that having any impact on ultrasound screening, if you will? Joe, you're nodding your head yes. Why is it going to make a difference now having handhelds versus carts?
Well, back to the screening, like if the guy who can fix it isn't the guy finding it, you're going to have problems. You're going to create more work for other docs, and that just makes everyone angry. And so if you're right, the right specialty needs to be doing the right screening. But another thing about screening is that the average healthcare CEO is in there for like 5 years, and the average ROI for screening is like 7+ years. And so if you're going to find a problem in a population of people, you better be ready to fix all of them or address all of them, because screening's just, it can cause a lot of problems. However, if you're a doctor and you've got your yearly physical, and that's the time. It's too hard to remember every test for every patient. I'm sure we all agree. But finding that time and place for the screen where you're going to see the patient, you make it routine, and then you remember it, and it's part of it. But there's so many docs out there that want to handle these problems, but they don't have the right tool, the right solution. So yeah, the screening should be by the people who are going to fix it, and it needs to be aligned with the practice. Yeah, I think I got that right.
Well, let me ask this question. Is the definition of fix it? So you're going to screen for carotid artery disease. You're a big fan of carotid IMT. Is fix it coming to me, or is it fix it to you or your docs who are going to put them on a statin, who are going to be more aggressive with that therapy and lifestyle changes? What's the definition of fix it?
Right. So 70% or more included, the primary care is going to kick it out to the vascular surgeon. Not his problem. But I also have to get that doc comfortable. If that's 60% included, that's your problem, my man. You're going to put the patient on a statin. You're going to tell them about sugar, give them the therapies that work, but you've got to own it. That's what I'm saying.
How do you guys think about screening? I mean, if we're looking at the group here that's listening to the, oh, there's one question in there. Is there a role for early cardiac ultrasound on a pre-hospital setting on an ambulance as paramedics? And are AI aided echo stethoscopes a worthwhile agency or individual investment?
That's for the
There you go.
cardiologist.
It's, we know that they are being used, are the ones that have trained in ultrasound. So it's like, just like some of the ER docs are trained in ultrasound, there are specialized fellowships, and all of the residencies now are requiring some form of training for some amount of time. That being said, if you're a paramedic and you're dealing with, chest pain calls or sudden cardiac death, someone's arrested, ultrasound can really help, not only help you if you're doing CPR, just to make sure, to take a quick look, but also in the event someone's having a chest pain, you can, if you can, exclude some catastrophic things, you can then triage earlier, and presumably, time is muscle. So we always want, things to be diagnosed quickly. So whether someone has an effusion, a pericardial effusion, or if they have, I don't know how well the ultrasound could see, but they should be able to identify, like, the walls are not moving as well, and there might be some kind of ischemic cardiomyopathy that's already present. And just look quickly at the aortic valve and the size of the proximal aorta. I think those are very useful things. And sometimes we do that in the cath lab. If somebody comes in and they've just been rushed right, skipped going through the ER, and they just end up in our cath lab, sometimes we do an ultrasound, because sometimes what happens is they shoot the coronaries and the coronaries look fine. And then you discover, oh, they actually have an aortic aneurysm, or they have some other problem, which we could have, picked up by POCUS earlier.
Yeah, we have a paramedic here who says, yes, I use POCUS echoes every day. And it's a little bit outside of screening, but I guess it's screening in the context of what is the acute pathology that's there on bus. And listen, you guys, I think we're all old enough to say the world of STEMI management has changed dramatically, from activating on the ambulance, because the paramedics are phenomenal at identifying this. And I think there's a world coming. I've trained, our team has trained the paramedics in my hometown, and they asked me, why do you want this so badly? And my answer was, because if I go down, I want you to know how to do this. And whether it's looking for a pneumothorax for somebody, or for undifferentiated dyspnea, do there be lines there? Or during CPR, there's really nice studies done out of Denver that show it actually helps and doesn't interfere with the protocol. 20% of the time, it had an impact on the CPR protocol. And so if you use it as screening tool, AAA's the right kind of patient, you get a quick look in a large AAA, that's helpful. And Francis Russell at Indiana did a great study on undifferentiated dyspnea and showed it dramatically reduced the time to treatment when paramedics were looking on the bus. So I'm a firm believer, if we want to call that screening, it's a little bit outside of what we typically say, But that kind of screening, I think, is very powerful, and we learn more. Um, Ben, what have I not asked? What about screening do you want people to leave with tonight and say, okay, we're talking about ultrasound screening. We believe there's a role for it. We believe there's more studies done here. We're clearly behind the eight ball with cardiovascular disease detection, and it's not getting any better. What should our next steps be? What should people walk away from this webinar and the chance of being around you to do differently tomorrow that they're doing today?
Um, uh, well, I'll make two comments just to sort of piggyback, John, off your last comment. I do think that what is clear now is that the world of time-sensitive decisions for cardiac emergencies has really blossomed, right? And that specifically includes treatment pathways for cardiogenic shock. And so it's not just stenting, but it's a whole other set of actionable insights from a look at the heart in the field. So that's number one. The other comment that I want to make that we haven't touched on yet is sort of the profound disparities of cardiovascular care that are present today in the context of the current modalities of case identification and care. And the simplest example that is getting a fair bit of attention these days is sort of how frequently people are referred for diagnostic quality echoes in the echo lab at any system. And rates of imaging, cardiac imaging, are widely disparate across sexes and across race and ethnicity. And so not everybody gets picked up and treated at the same rate. And that is a de facto observation about care today. And so what I would leave people with is that these new tools that Butterfly and others have put into the field have an opportunity to bend those arcs. And if we know how to scan and we know what we're looking at, and then importantly, we know what we're not looking at, we have a real opportunity to improve outcomes for patients with the right evidence base.
Joe, how would you
Yeah.
answer the same question?
Repeat the question just so I make sure I answer the right one.
What do you want people to walk away with today? What did I not ask? Do you think is a clean message from what you've learned running the business that you've done? And what knowledge and experience of your expertise could you pass on to people you think that would change the way they practice medicine tomorrow than the way they do today?
I think it's worth it. The investment in time to learn your first little ultrasound body part and get good at it is rewarding and brings you value to your patient, and you have something to talk about and it's engaging. But just use that skill and learn that skill, and it's worthwhile just because of the communication, the honesty, the trust that's built between you and your patient when you're seeing the same thing and identifying the same problem for the first time. It is motivational, it is empowering, and it's a relatively simple skill to learn, but it delivers so much to your patients.
So Rita, you've been involved in screening for a long time. That's why I've saved you for last, is that this is a passion of yours. What are you working on today that's going to change things for tomorrow? And that experience you've had, you go back, you're getting close to almost 10 years now. Wow, it's been a while. Looking back, we're that big project. Where are we today compared to then? And have you seen it? Yes, it's published. Yes, it's referenced. Have we changed really behavior enough that we're making a dent in things, or what are you working to change the future of screening with ultrasound?
I think it will depend on how well we can teach ultrasound. So cardiac ultrasound, for example, because cardiologists are so busy. We're so busy doing echoes and structural, and they can't. Here at Pitt, for example, the ER people are teaching, not the cardiologists. They can ask us a question, but we're really out of that sphere now because there's just so much other pathology we're dealing with. But from a screening point of view, can you imagine if we could train enough people, like you have to be at a certain level so you're not getting false positives or missing things and getting false negatives. if we can lower those two things by the way we're educating, so through simulation, through virtual reality, and those are really forthcoming. I think there are businesses and other models that are really incredible, and I think will lead to more and more people understanding how to do this technology, use this technology. But can you imagine, say at the Super Bowl, you had blood pressure screening, which, you know, is routine at NFL games. But instead of a blood pressure screening just with a cuff, you had a POCUS device and you screened their heart, you know, along with, so maybe another minute. And the information and seeing is believing, you know, that would go a long ways to opening people's eyes that are outside of this realm into seeing that, you know, this is something we should be doing. You know, it's a tool. Why would I use my old black dial telephone when I have the iPhone? You know, it's the same logic for me.
Because I can keep you off social media if you No, just kidding. Just kidding. No, I think, you know, you guys all pointed out some important things. There's now technology devices that make affordability and availability something that's now conquering that hurdle, which is a big one. The second thing is, you know, we're building a foundation, if you will, of education at that level that is going to take time to emerge up and to be the drivers. But we're also building artificial intelligence tools that are getting really powerful at being able to detect pathology, to tell us when something's normal or not. And certainly being used a ton in radiology for taking images. That world is coming to ultrasound as well. And tools, you know, Heart Focus, Caption, have built those to make learning this easier. Um, I think the last real hurdles that are out there are the scientific data. And one of our comments in there says, yes, you've all agreed their studies need this butterfly fund that. We do fund some stuff, but these are big studies that are incredibly expensive, that are really kind of societal, if you will. These are NIH level, big time ARPA-H studies that are going to be necessary to take that over the hump. But I think the realization, if you will, that what we're doing today is not good enough, that the stethoscope is great for a symbol of a doctor, but that's probably where it ends, and that we need to all push harder, that ultrasound skills should become a core of what we do. And then as leaders, we got to give people time and motivate and value learning this skill set. And maybe the biggest thing of all is learning what normal is. If you can learn normal, you're three-quarters of the way home. And I think people spend not enough time recognizing normal, because if we can wipe out normal, then we can dedicate those resources toward those others. But I think kind of the bottom line message from all of us here is there is an opportunity here with ultrasound to screen better for cardiovascular disease, to identify things earlier so our treatment modalities are not on the back end of the disease, but on the front end of the disease, where interventions are not only more effective, but less expensive, and not only add more years to life, but more life to years, because the quality of life will get better. And my hope is that people will take this and then run with it. And I'm very grateful to you guys for sharing your knowledge and expertise. It's a complicated subject, you know, because there's so many variables that swirl around this. But I think with leaders like yourself still driving it, there's hope out there. And I would certainly recommend all to, and I'm sure you guys are, reach out to these guys. I'm sure they'll share their expertise with you. And any parting words each one of you would like to make before we close this tonight?
Just do it.
Oh, Nike would be so proud. We're about to get sued. All
I
right.
love bringing back the healers, the doctor and the patient relationship. I love the transparency this fosters between that. The healers are coming back.
Ben, last word to you.
No, I think the discussion is great. It's not a one size fits all approach. And I agree with you that education is going to be the key.
Thank you all very much. We look forward. This will actually live on Butterfly website after the editing's done. So please share this with your friends and colleagues. And we look forward to you joining us in a future edition of a Butterfly webinar to help educate everyone on the value proposition of point of care ultrasound. And it's Heart Month. Make sure your friends and colleagues and appropriate people get screened. Finding a screening location or talk to your doctor near you. Thank you very much.